quick about my part of it. I think that Dr. Bolfa probably has a little bit more to add than I do, but I would just like to say that on behalf of the foundation, we are very proud to sponsor this very impactful, I think, series of seminars, these 2 seminars this month, again, co-sponsored by the ACVP, but we're proud to support this both as sponsors and hosts of the seminars and also via some of the work that Dr. Bruce Williams is doing with JPC, helping to house and organize the biobank, and Dr. Mutin will talk a little bit more about that. So we're very grateful that we could provide the platform for this really, really impactful discussion to start happening. And I hope that there's a lot of buy-in for this because I think it's a fantastic initiative. So Dr. Bolfa, on to you.
Good morning, everyone. I hope you can all hear me. I will be very brief as well. I just want to start by saying thank you to Davis-Thompson Foundation for hosting and co-sponsoring the webinar. Also for co-sponsoring and hosting the Future Biobank. You'll be hearing more about it today. Thank you to the ACVP for co-sponsoring this seminar series. Also, I want to encourage everyone, as it was already mentioned, to provide us with feedback. VCGP group is really looking forward for more volunteers, for more people to get involved. And hopefully the talks today will convince you that there is a lot to do and that there is a place for everybody to contribute. Thank you again, and looking forward to some great talks.
Thank you, Dr. Kohler and Dr. Bolfa. So now we're gonna go to Dr. Don Milton's lecture, and I'm just take a quick moment to introduce him. So I'm very honored and very pleased to introduce Dr. Don Milton. Dr. Don Milton is a retired professor emeritus from the College of Veterinary Medicine of the North Carolina State University. He received his Bachelor's of Science from the University of Connecticut in 1970, his DVM from Cornell University in 1974, followed by a PhD in veterinary pathology from the Ohio State University. He's board certified in both anatomic and clinical pathology, also involved in countless publications, and has mentored many students throughout the years. Dr. Milton is the editor of the textbook Tumors in Domestic Animals, and currently involved in the group leading the Veterinary Cancer Guidelines and Protocols. Dr. Milton, thank you, and over to you.
Juan, that was very nice, very short, right to the point. I greatly appreciate it. Any names I mispronounce, I'm sorry, for Juan, Rafael, tell me if I got to tilt my screen and so forth. These Zoom meetings where I sit all by myself in a living room, I have no idea if it's proceeding the way it should. But let's get going. Everybody has done a nice job thanking each one of these groups, and I certainly echo all those sentiments. Thank you very much. This is the topic I'm supposed to present. Any one of a number of people as part of this organization could have presented it, and I'm the one that will get the opportunity. We'll see how it goes. But I wanted to take a moment, and I got to be careful I don't get emotional, to say goodbye to Dr. D. You can read the words, and this will fix it for me. You know, before there was this book, we actually had to sit in his class and take notes. I can remember Marina saying, how many Dr. D lectures can you get out of one ballpoint pen? But it's hard to believe he's gone. Go to the memorial site if you would. I don't know if Dr. D would have chosen it, but I think he might have. That one of the very numerous statements that was there was that he was one of the best teachers anybody ever had. It was incredible how he could take us with a towel under the animal's flank and hopping along all the way to the histopathology as if they were one and the same. But he has a great influence on me and many others. Brian Summers reminded me that what a team Dr. D and Dr. Cummings had. It was terrific. And he was certainly a gentleman and a mentor, and I think very humble. So if you've got a mentor out there, remember to send a note of thanks, because you never know when you got a few cells degenerating or a few cells proliferating. And if you're going to ask me, did I send him a note? I did. So, but if you've got one out there that meant something to you, make sure you pass it along. So now we're back to that introductory slide. Hopefully everybody can see it. And Jay said, why do we even need to standardize? How can we standardize? You can read the words. The one I can answer right away, how can all of you be a part of the conversation in our effort to move this website forward? Just contact us. See the website, Mike Dark will give you a tour. There's all sorts of email addresses, because this idea is not a private club. It is open to everybody, and we want your feedback and we want your input. I mean, if you do some parameters differently and you think it's a way that we should consider, by all means communicate with us. And I think on the website, it'll be clear who you can communicate with. So the question, what's the site? Mike will be the one that really gives you the tour of it and identifies. These are the talks that we're going to go on today. And then at the end of the month, these other components in VCGP. And I think you'll really enjoy each one. I particularly like lymphovascular invasion, Mike's synoptic reporting. So hopefully some or many of you will come back at the end of the month. This to me is still number one. We've got to have outcome assessments, because those are our grades. So this team approach of working with clinicians, I think, is absolutely vital. So Jay, if I could pick an easy way to say why standardize, I'll beat it to death and I'll give you many more slides than this, but to me, it's just common sense. The questions that I find a little more intriguing might be, why haven't we? And isn't that incredible that we haven't? The overall goal of the organization is improve the care of animals that have cancer. Of course, we have a mission statement, and I'll get into some of those details, but that's the overall goal that we hope to accomplish. And what is this website? We think it's an educational resource, international, that provides the benchmarks or the guidelines that we should use when evaluating tumors in animals. It's primarily for aggressive tumors. We haven't been able to resolve certain confounders that are practical considerations, such as what do we do with the benign tumors, but let's start small and we'll expand from there. And I do want to emphasize this. Oh my gosh, 2011, Vet Pathology published a nice series of manuscripts, and I'd like to think we're a continuation of the work that these organizations started. And I'll get this message across in multiple times. We really want to recruit others to help us with this effort. And these will be components that are present within the website. Copy is one of my best buddies ever. And that's what it has to do for so many of us. How can we improve the care that these animals, pets, have with cancer? So you don't need any notes. There'll be very little that I have to say of import, but the key thing is to read. So there'll be several online sources. I assume this talk will be kept for a period of time, but this is the website that's up here in the corner. This is a manuscript that Fran Moore and others put together recently, and that's got numerous references. Sort of modeled the idea off of this website with College American Pathologists, and apparently that is a private club. Ours is not. I tried to join and they said, thank you, Don, but no, we don't need any veterinary pathologists. a bit of a paraphrase, but I'm still working on that angle, and I would like to be a part of several groups. So read, and that's where the references are going to be. Today, just sit back and listen and correct me when I make errors. So the reasons to standardize that we discussed, we think are pretty simple and straightforward. And many times I might say for me, but hopefully it always represents the group, a major function is to validate our studies and validate the methods such that we can reproduce or replicate what other people have done. Dr. Smedley's done a great amount of work with melanomas. We need to make sure that the materials and methods are described such that others can reproduce those and see how close the results are compared to the original studies. We're going to need journals to help out with this and publish studies that do in fact attempt reproduction or replication. But this is a huge step, and it's one that I think in veterinary pathology and oncology, we haven't done. We need to compare, combine, merge data. We need to get away from studies of 20 dogs, 15. I can exaggerate, but exaggerations aren't needed, and they border on untruth, so I shouldn't do that. But we need large numbers of cases, but the methods have to have been done in the same fashion, or we cannot merge the data, combine data, and compare it between studies. And that needs to be done stepwise, actually before it's used clinically. And I think in vet oncology, we've gotten a little bit out of step in that regard. So the guidelines that we put together, you could look at those as best practice methods, but they're more than that because they include confounders that can't be standardized, some review of the literature, and I really like the suggestions that authors have put at the end of the guidelines of the way to improve. And that's where you, as a listener, fellow colleague, can provide information for us. And outcome assessment is a guideline, I think one of the most important. We want these methods to be prognostic, help us predict how a tumor would behave, but it's the clinician that assigns the prognosis, not us, the pathologist. And we hope that they'll predict treatment selections for the clinicians as well, and they'll consist of these parameters and protocols. So go to the website and go to the publication and you'll see expansions on that. Now Google standardization. What is it? And I liked what I found, that it's a procedure used in science that increases validity and reliability. Can you reproduce, validate results that are in the literature? Those methods should stimulate confidence in terms of the people that do develop them, as well as those that then use those methods as well. Because what we want to do is create the new knowledge, but we also want to validate or refute existing knowledge. It's got to be reproducible before we apply it in clinical situations with animals. So for us, this is really about the behavior of tumors. If we don't do this, how can we compare results between labs? If we don't do this, how can clinicians rely on the parameters that we report to them if we're not all doing it with the same methods? So, Jay, I'll just keep giving you questions. Why didn't we do this earlier? I don't know. Maybe we thought we were all using similar methods, but I'll tell you what, in the 1980s, I did not challenge Dr. Capon, Kasiba, Hoover. They were my mini gods. And I accepted that this is how that we evaluated the tumors. But I think this lack of standardization can explain some of the contradictory data and the inter-observer variations that we'll often see reported and that people keep trying to correct. This is where I'm sitting. Bruce likes it. Mike Dark is worried the internet's going to cut me off. The wiring's not so good in this cabin, but we'll get to that in just a minute. there's a lot that goes into a word. So if you don't like the word we chose, standards, benchmarks, guidelines, at least agree with the principle that we need to standardize our methods. If you have other words you want to suggest, feel free to share those. Why haven't we followed this series of publications that started in 2011? Yeah, I'll expand a little bit on that. But I bet the majority of you agree with the principle that we should. Now you can really help us by editing as well as using these methods in your workstations and report results as they're being outlined. We really do want feedback, and we need lots of new protocols. I will never attempt a protocol on mammary or lymphoma. Oh my goodness. But the Amy Durhams of the world, or the Peter Moores and others, perhaps they'll help with these. I've got a group that I think would do a great job with osteosarcoma. And it's very important to me that cytology be included in this effort as well. So I'm trying to recruit Paula Kramer and Amos and others to help in that regard. Well, this is a theme that I'll try to repeat, which is these methods need to be standardized and described in such detail that others can duplicate them. And I'm not talking just about a mitotic counter margins, but any more sophisticated techniques that come along that help predict how a tumor will behave or select treatments. They need to be described in detail so that each lab can repeat those. We're going to need outcomes, and I'd love to see people compare the new method with existing standards so that we can see how much better the method is or not, at what cost of infrastructure, of people, time, money, and so forth. But you got to stop saying this. Mutant lives in a log cabin and he only wants us to use the mitotic count. Absolutely not. I welcome change. We need to validate the basics as we move forward. And maybe that's where we rushed, stumbled a little bit, and got out of step as we assumed all the commonly used parameters. We were doing the same, and we went on to more sophisticated techniques, perhaps. So, should we standardize? Is it present in our world? Oh my gosh, this is just a little bit of evidence to say it's all over. They got standardization for the mini pig, for semen. We need to step up and do it for our discipline or our industry, which is cancer pathology. So the goal is we'll get uniformity with labs across the world within our discipline. I'll just pick one example because I do like it, the mitotic count. And Doctors Bertram and Donovan will expand on this in much more detail. But high-powered field, it's not a unit of area. Unit of area for standard international units is millimeters squared. Karen Donovan and colleagues put together these images, which I think nicely show the relative field of view if the ocular is changed. So they're all at a similar magnification, but the FN field number on the ocular is wide. The most common that pathologists have are narrow, perhaps Dr. Patnick and Bostic. 4 mitotic figures, 2 mitotic figures, 1 mitotic figure. All at the same mag, but with different oculars on the FN. I like what other people say more than what I say. So read this article by Bonaire. There's the reference down here, and look at the terminology that they used. These fields of view should be completely abandoned as measures in pathology. It's offensive that for anyone that's given thought to why measures should be used. So I think that's pretty heavy. My buddies in ClinPath, your analyses, oh my goodness. Low power field, high power field, we use it frequently, and we need to get on board in ClinPath, because ClinPath is really the leader in my mind compared to anatomic when it does come to standardized methods and so forth. All these are meaningless for what may be the number one way that we evaluate tumors now, which is on whole slide images. So to back up a bit, these are the three oculars. This would be modern day scopes that have a very wide field of view because the FN is large. This is narrow. Older scopes, Zeiss and so forth were probably equipped with these type of oculars. These are MD's. CAP even has errors about the field of view. So we shouldn't worry that it's just us. The MDs started to recognize this in '81, and there's still publications coming out 40 years later that talk about the incorrect usage of the field of view and how it's reported. For us, George was the first one to identify it in '99, and then Fran and others put together a manuscript. But in 2021, people are still using mitotic index, which none of us ever did. Christoph will expand on that, and they're still using a high-powered field. Doesn't matter on which one of these you'd use. We did our work on this one because FN22 is the most common ocular manufactured for pathologists, MD and veterinary pathologists. And then the exaggeration down here would be the mitotic count as obtained with a wide versus a narrow. You can see the difference in the numbers. No oncologist would rely on one parameter, but the treatment would be quite different if you were only looking at the mitotic count, which also brings up to the point, never just use one parameter. It's got to be a combination. Anybody that's still awake will now go to sleep as I show an objective, as I show an ocular. But what I really want you to do is go to Mike Dark's website and look at abbreviations and definitions. Greg Miller, if you get ready to write exam questions, they're just loaded in this part of the website, and you can confirm it with references or other websites that are listed. But I got to thank Jay Kolish. She knew about the FN of the ocular. She said, I got an FN on the objective. And I said, no, you don't, Jay. It's only on the ocular. Well, Jay, of course, was correct. Every objective has a field number as well. Sometimes it may be engraved. There's websites on what all these different numbers and letters indicate and so forth. So if you find an FN on the objective, don't panic and email me and said we blew it. In fact, the rate limiting factor is still, as long as there's eyepieces, the FN on the ocular. We'll go read the definitions and abbreviations that will expand on what the FN on the objective could do if you had a camera. So thank you, Jay. Thank you, Kurt Zimmerman. This shows the calculations for how you can determine the area, pi r squared. And you should probably check with a stage micrometer, but there's two different types of stage micrometer. And if you're actually going to check the accuracy of the field of view, you want to use the most expensive stage micrometer. My microscope people that I consult with say, don't bother. The precision in the manufacture of these is such that you using a naked eye to look at the stage micrometer is going to make more errors than if you just did this simple math calculation to determine the diameter and then the subsequent area. That's a standard unit of measurement. High-powered field is not. So Fran put together a nice explanation for how you can go to digital pathology and calculate the area, because high-powered field is essentially meaningless with perhaps the number one way tumors are being evaluated in vet medicine across the world right now. And at each of your workstations, you need to determine what the field of view will be for the area to be counted. And in the website or in Fran's manuscript, they detail how that's to be done. Pay attention, please, to Drs. Donovan and Bertram. They'll expand on all of this, counting mitotic figures, atypical, not counting mitotic-like figures, not counting prophase. And in the original MD literature, they wanted to count telophase too. Karen can expand on why they did that, but in our attempt to standardize, if you should see a telophase, it's counted as one, which I think, again, goes back to common sense. And then this indicates how it should be reported. There'll probably be some adjustment period, although it seems like that would have gone on long enough to say that this unit of area should be equivalent. And we got to be careful of that because I've got no idea what Patnick, Bostock, the two-tier system, how big their fields of view were. But this simple little diagram shows what was probably the diameter, the field of view in scopes back in the early 80s compared to be what they might be now. So some of you need to go to the clinical seminars, oncology and so forth, and explain, I don't know what the field area was that mitotic figures or other structures were enumerated in. I think explain is the word to choose. Part of me feels like we should apologize. I've said to my clinical friends, this situation, and some have responded with, wait a minute, are you saying you don't know and you may be counting mitotic figures in different sized areas in different labs? And up until recently, we have to say yes. But now let's get this straightened out and add new techniques as we move forward. So we've covered this one. But I do want to point this out. Here's an article that came out of this journal in 2021. I think when other people say it, I like it, and then I can use that for vet pathology as well. They pointed out that they need the journal editors, reviewers, and authors to stop using the term high-powered field and insist that whatever structure is being enumerated, that a standard unit of measurement is actually used. Similar language to the Bonaire, high-power fields should be abandoned. And I hope that we'll start to do that in our veterinary journals. It hasn't happened yet, and it would be replaced by that standard international unit. And we've covered WSI as well. So read these articles. And this started for the MDs in 81, 40 years later, and there's still publications coming out to say they haven't fully adjusted. I hope, here's one where veterinary pathology, we're not going to wait 40 years before we also get everybody on the same page. So Cree did point out that cell proliferation will continue to be assessed for these purposes that we all do. I would insert that we should also compare it to other proliferative indices. So I want parameters that we can all do with H&E stained materials, but we should also compare them and see if there are better ways to assess how fast those cells are turning over. Cree also pointed out that we need to update the information, the knowledge on these different tumor types, because of this was used in the original studies. That's very true for us. I won't continue to point out names, but you go back to any of our original foundation studies, that's what was used. Now we know that it could vary by 200 to 600%. 600% is a little bit of fake news. I shouldn't use that, but 200% at the same mag. And also because the treatments may be different now, so that older information is no longer relevant when assessed with modern day techniques. We need to revisit, repeat those studies and have larger studies, maybe from the biobank. And don't just leave them once, but if we can have a system where we review that as times change, it could be very useful for all of us. So if you're a young pathologist, what a great time to go back and repeat studies as well as introduce new techniques. Oh, they went on to say that some of the standard text need to use the same terminology. He cited references for melanomas that when mitoses were enumerated in a defined area, that they got very good inter-observer reproducibility. In contrast to earlier studies where there was poor inter-observer reproducibility. If we don't use the same technique, the same method, you can't compare interpathologist variability. So we want to reverse this trend by standardizing all the parameters that we use in VetPath. Oh, ho, ho. I cannot see the audience if anybody is finding this humorous at all, but our standardization of the basic parameters is a mess. It's very easy to fix this one, and this one. We'll have people talking on each one of these, or you pick some that you'd flow cytometry, they're ahead of us in terms of trying to standardize those techniques. I mean, if we're not using the same antibodies, how are we going to know if we've got the similar ratios of B cell, T cell lymphomas, and so forth? And these techniques have to be described in detail that they're reproducible across labs, because we are an international organization now, and it's not just one lab that's reporting the results for a specific hospital. All right, human oncology, and it's the same for us in veterinary. The standardization should adjust the lack of reproducibility. So is there a lack of reproducibility out there? Certainly for human oncology, there is. Look at these statistics, and you can read the manuscript to get the references and see more details. Less than 10% of observational studies replicate. 20% of preclinical cancer trials can be replicated. Absolutely. This is in human oncology. In veterinary oncology, we don't even attempt to replicate a study. I'll expand on that for just a minute. So Dr. Smedley, sit on your hand for a second. But validation and grading schemes is impossible if those original methods can't be duplicated by the other investigators, or those methods were flawed or inadequately described. This is just one example. We can go through that with margins and other types as well. Here's some references that deal with the human side of it all the way through here. This is a long report, but it would be interesting to read. It's current 2021, but all these manuscripts deal with this concept, the lack of reproducibility, studies that will replicate, and therefore a weakness in our data, in our scientific reports. So how far have we gone in 41 years? 1980 with Patnick and Bostic, and we haven't gone very far at all. In fact, we don't even do validation studies for our grading schemes. It appears that once somebody puts a system in place, we just use it, regardless of whether it's been validated or not. Validation studies are definitely needed, and we need journals that will publish those. We don't know how that system is going to behave with different people evaluating it, with different pets, horses, and animals. Authors should feel complimented when colleagues attempt to reproduce their methods. And journals need to recognize the importance of this. Journals want to publish, have a high scientific impact, publish new novel results. There is a need to publish validation studies. So if Paul Stromberg has 20 cases of tumor X, John Mutant comes along and now has 30 cases of tumor X and says, yeah, Paul was right. Is VetPath, JVDI, and so forth going to publish that? Those are needed. The N needs to increase greatly, but bring in new tests at the same time you check prior methods. So I think this is just a fabulous manuscript. You should all go read it. And definitely read the tables that Dr. Bergen, Smedley, and so forth put together, I think it's a great model in terms of validation and introducing a new technique, Ki-67, to evaluate those melanomas. This is a super paper as well from the Guelph people, where they attempted to validate existing grading schemes for osteosarcoma. So there's grading schemes out there for a large number of tumors. We all know that. There's consensus reports on which one you should use. Consensus reports are not validation. And that is what we do need in veterinary oncology. Studies that validate with different pathologists, different patients, and see what those results are. This is the Young paper. I'll leave it at that. Take a look at it. But he does talk about this irreproducibility crisis in scientists that cannot replicate their claims. And he expands it in terms of, if you want to read it, university compared to industry, and puts in a real plug for industry that they do, in fact, immediately have consumers that are going to use their product or use the data that's being reported. They've got to be accurate and accountable immediately. So these are the people that put together this recent manuscript, and they expanded in terms of why standardize, and it centers around this validation of our existing grading schemes. It will increase the confidence, the significance of the results. But so far, we haven't done this in veterinary oncology. So this article, the website attempts to address this by producing these guidelines, and the website to both house, but more importantly, update. And these updates can be done rapidly. We don't have to wait for a new manuscript. We don't have to wait if there's data-driven results or a new book to come out. So I think that's going to be a real advantage of using the website. Why didn't we listen to all our colleagues 10 years ago? They're excellent articles, and we use those to summarize information. And I think perhaps it was because they summarized the literature, but they didn't prioritize or choose a method. They still left it for each lab to decide how they wanted to do it themselves. But we hope that this is a continuum of that excellent information that they started. But now we're focusing on establishing the standardized methods for which tumors should be evaluated, and then we all need to use those. So this represents the best practices for the methods, and protocols expand upon that for specific neoplasms. We only have a couple of those together. So Jay, check that one off. I'm done. How can we standardize? Agreement is the best way, and that's going to be the tricky part. And then use what's being published, which can be updated if you'll contribute. And if you want to work with us, email, contact. It's designed for all of us. It's not a private club by any means. And to be relevant, it needs your input. So Mike can expand. Let me see what time it is on some of these parts of it, but the guidelines provide the standardized methods. Protocols are designed to gather large data sets with as many parameters as the authors felt were pertinent for that particular tumor. Read the one Fran put together on soft tissue tumors, and it's going to expand. There'll be a group at the ACVP meeting that will be talking on that as well. But I think it's an excellent one, and it challenges some of the premises of the original manuscripts. And that's the ultimate goal, improve patient care. We want to keep our basics standardized, but we welcome new techniques. And the journals are gatekeepers in this whole process, or one of the gatekeepers, and they should insist on comparing any new methods, even molecular methods, to what are the existing methods that we can all do at our workstations, so we can know how much better the new method is or not, at what cost of infrastructures, and so forth. That medicine does not have tertiary payments. We will always have owners with limited resources. Look at this log cabin I'm in, and in Appalachia. Trust me, those people are not going to pay for novel tests that we might recommend and believe would be more prognostic or predictive of a treatment. We need to do a good job with our basic parameters for these pet owners that may love their animal just as much as someone else. This is a heavy duty one. Reject manuscripts. Require pathologist review of case material for the oncology studies that only use case records for the path data. That's got to stop. We didn't standardize how the path parameters went into the record previously to go back in a decade-old study and put together those reports without having a pathologist. That's erroneous. So I hope I can convince that we can convince editors that they need pathologist review, and we'd be glad to suggest pathologists if a journal actually needed them. So the DCGP checklist can be extensive, and reviewers and editors can use those to see if the current authors followed that protocol. So who's going to use these guidelines? That group. I think they will welcome this standardized methods. I'm not so sure the older generation is going to like it, but this is our future, and I believe they will. So there's a whole series of these, I think about 7. In protocols, we only have 3, so there's great needs. Rebecca Smedley will be talking later on today on melanomas. And if you've got inputs for any of us, please provide it. Diagnosticians, researchers, and journals will use this. The protocols are so detailed that perhaps the diagnostician should read, but there's almost too much information for those to be on a practical basis. And if Rebecca corrects me, then you listen to her. But for both of these, the guidelines and the protocols, we need some concise, short versions, cliff notes, if you will, that can be summarized in a page. If you go to the website, I think you'll find now that they're fairly complete, and therefore shorter versions would help diagnosticians and other users. These are areas that we definitely need new guidelines and protocols. So that's the goal, and it would be for animals, not just pets with cancer. Those are some of the guidelines that are there. And this is the concept that I really like, the fact that they can be updated and those versions posted. Mike can walk you through that. Of course, there's a mission statement. I won't go through those and all the details that are there. Come back at the end of the month and hear Mike talk about synoptic tumor reporting. I view the whole process as an educational resource. We're trying to come up with these short checklists that would be useful for editors and reviewers of manuscripts, especially of clinical manuscripts that might have pathology data, so that they can see that all the correct components were looked at. This is an exciting future that Fran, Bruce Williams, and JPC will venture into. They're at the ground level. They seek help from multiple people, but what a great way to resource share and bring in new technologies and validate existing parameters. Can you imagine if somebody has 200, 500 of a similar tumor with outcome assessments? Researchers would clamor to apply their technique to assess those tumors. So I really think this concept is an exciting one to try, and we'll succeed. These are people that have different tasks that are assigned here, add your name to the group. We've got the path-based and clinical-based folks. And now I'm going to check my time while I don't have much time, darn it, have a cartoon to read. And from my good buddy, John Cullen. Of course, I can't tell if anybody finds anything humorous. So let's just move forward. And this is generic. This isn't Democrats, Republicans, you pick and choose. This isn't America. You can pick your country that you want to go in here, but that could happen. All right, I've expanded what those are. I really like one component in the guidelines, which are future considerations. And I like that because it's ways that guideline can be improved. I had a colleague tell me, I'm not going to tell others my ideas. I'm going to keep those for myself and do the research. I hope this will change. It's just going to slow our progress. We need to improve, prioritize how to help these animals with cancer and prioritize that over the publications, funding, and so forth. This, I believe, will be a game changer. However, these multi-authored studies that could come from this, we need department chairs, we need deans, section leaders, and so forth. How are you going to recognize excellence beyond just the first author in these multi-authored manuscripts? So I've started to contact each of these folks to get some input, and they're all for multi-institutional studies and multi-authored manuscripts with large N of the cases, but how they're going to get recognition for those, I want these people to put it in writing so that other individuals will contribute. I don't know. Oh, these were just specific examples for the mitotic count. And you can read about those. I don't want to go through those right now, but I can see a future where 2.37 is not used, that they may use different size areas for different tumors. They already do that in CAPS. Adrenal tumors that may have very low cell proliferation, they change the area that's enumerated. I've always liked this one. I don't care what the mitotic count is in one spot, one hot spot or one more invasive spot. Maybe it's important to know overall how aggressive, hot, numerous mitotic figures or cold that tumor is. So there's lots of room for ideas and new techniques to be tried. But the first thing, we got to standardize how we all evaluate the cases, path parameters, as well as outcome assessments. And they're just vital that we've got accurate outcomes that are collected as carefully as we do the path parameters. And then we should validate those results before they're applied on clinical cases. That's an exception to the way we work in vet oncology, but we can move forward with our present system as we also amend it with this. And journals need to accept those validation studies. Large numbers, we need to join forces. It's got to be a team effort. If we don't do this, we're going to continue to have studies that contradict information and we can't compare. The large N is a big factor. 20, 50, how can you accurately determine recurrence of metastases? There's a manuscript that has 236 cases, which looks absolutely great, but only 139 are graded. Only 86 that are graded have follow-up. And then only 9 are high grade and only 4 have follow-up. 3 of the 4 recurred. 75% is an accurate statement for that study. But the rest of us should not repeat that 75% of these STTs or STCs recur. That needs validation. It needs study with a greater N, and I'm sure the author would agree with that as well. So will journals publish repeat validation studies? They really need to. Donovan and Bertram will expand on all this. Donovan and Corbin will talk about necrosis today. You only use histopath. Should we use gross? We've got no real way. We just say, yeah, go ahead and guesstimate how much necrosis is present in a tumor. But I do want to point out that there's a publication that states, and I think others use it, that dogs with this particular tumor, if there's greater than 10% necrosis, almost 3 times more likely to die of the tumor. Yet the data relating to that was not reported. And it's not in the materials and methods. Where did this come from? We accept it, and we don't challenge it. And I hope we can now move forward and start to challenge some of these dogmas. Outcome assessment from our clinical oncology folks will be vital. And survival time, how often has an assigned grade, that's a high grade tumor, ended the dog's life, horse's life, that may have lived significantly longer. So euthanasia is a blessing in many regards for veterinary medicine, that the animal shouldn't have to suffer. But it really skews our data. Therefore, disease-free intervals, other parameters that can be assessed, those are going to be more important than overall survival time. Nursing care, how that influences euthanasia is a major factor. Metastases, you'll see this in our definitions. We really feel it needs to be reported as confirmed or suspected. When imaging is the only way to identify metastases, there's no validation that that was the same tumor type. It's light microscopy that's going to confirm that those mets or recurrences are actually the same tumor type. And this is where we need journals to accept these premises. Autopsies are becoming rare. The value seems to hit a low point. Yet, the studies that include autopsy data definitely increases the objectivity assigned to recurrence or metastases, and therefore increases the confidence in the study. I think researchers should set a target of at least 20% of their cases have autopsy data, especially in this day of age of cosmetic autopsies, cremation. The data that can be gathered from this is very reliable. There's selective autopsies. So we really need everyone, and especially the clinicians, to help in that function as well. For instance, might the survival time be different if values for life and the role of pets in the family are different? Might these survival curves vary with high and low medium income households? Secondary and tertiary care centers, will they have the same outcomes as primary care centers? So I know these individuals are actively involved with it. I hope we can recruit some to help with VCGP, and certainly Milan, Tina, Nikos will help with that as well. So what's practical in vet medicine? Are owners of these pets, I mean, you got to wonder, why did they bring the kitty cat in today? Are they going to pay for a novel, unique molecular test? Additionally, just knowing how long that tumor has been present may influence outcome assessments. So I think it's important for us as pathologists to remember and remind clinicians if needed, we can never predict how a tumor in either of the two dogs is going to behave. All that we can do is predict some probabilities, how similar tumors behaved in a prior study. And likely it was only one study. We don't have theranostics yet in veterinary oncology with individualized medicine. And to accomplish that, we may need the molecular profiles, not only of the tumor, but of the host. We look at the tumor because that's what we're trained to do. But the host gets to vote on what that tumor does as well. And the molecular profiles in these pets suppressor genes, and so forth may be very important to look at. Look at the tumor because we can, but we should probably look at the host. When do we stop? Presently, we can predict mast cell tumors in dogs very well. Everyone wants 100%. I can't deliver what everyone wants, certainty. This is biology. There'll never be 100% predictability. If you see a study that's got 100% specificity and sensitivity, you need to look at that with a jaundiced eye. We can't deliver certainty, even though that's what each individual may want. So finally approaching the end of this, and I really want our new studies to compare it to the existing. H&E is going to remain the foundation, the basis of pathology and veterinary oncology. Diagnostics will rely on it, and diagnostics will advance as the research happens with CPath, artificial intelligence, and so forth. But we also need reliable data that assesses the most important terms of outcomes. Did the tumor metastasize and did it recur? And journals are our gatekeepers for that type. If you're gatekeepers for these assessments, if you're a young pathologist, clinician, what a great time, because I really feel the old studies need to be repeated. And I encourage you, get perspectives from people that have done this for 50 years, 40 years, and it will only enhance your study. So, as a tribute, where did this whole idea come from? These people, I was trying to put together in the back of a book, Cliff Notes versions of how to summarize tumors. And I like this. The goal of counting mitotic figures is not to find the average number. It's to find the area that predicts an outcome. And that should be the goal of all our parameters. What outcome can be predicted? So Jeannie was the one in 1999 trying to estimate platelets in an oil immersion field, what was normal, realized that the FN of the ocular changed the size of the field of view to assess the platelets in. Fran said, you need to go read what Jeannie wrote. Dr. Whitlock was a great medicine individual at Georgia, at Cornell. Jeannie in her much younger years, and they published their results in various articles. And I got to give Sarli a lot of credit as well, because he started this process also a little bit before Jeannie did. May not have said quite the right stop there, but everybody needs somebody like Fran in their life to keep things in perspective, and a Kurt Zimmerman. So later on, Dr. Smedley will talk about melanoma. She's really advanced how much we look at this tumor. And I do like a study that Glenn Esplin did at an earlier time. And he looked at defining oral melanomas that were not aggressive. And he used some very basic parameters that we could all do. And I use that as an example of a manuscript that did use H&A, did use other parameters, but then Bergen and Smedley expanded on that by applying Ki-67 to those tumors as well. So it's very complementary the way they work together. At least I think it's that way. And Mark Simpson has done some things at NIH, and he'll certainly develop molecular techniques as well for the diagnosis. So what are the consequences if you don't follow some of these guidelines and protocols? Zero. There's no certifications at risk. There's no plaques of accomplishment awarded or rescinded. We think these are best practices that we will all follow. And then we're going to get reproducible results and consistent results. But we do need the shorter versions of each one of these. So these were not certified by any standards body. We just don't seem to have the courage to do that in veterinary oncology, do we? And they represent our interpretation and application of the data reviewed. A lawyer helped me design some of these words, and I think you can see that there. Now, whether somebody else is going to step up in the future and actually be a governing body, I don't know. I'll be long gone by then. But the success of these guidelines are going to depend on how widely you use them and how widely you help us improve on those. So that's the bottom line. Outcomes will remain the #1 grading scheme that we all use for our parameters, and it's going to take a team approach. I know these individuals will lead it. These individuals have certainly helped, and now you can step forward as well and contribute. We need to know the molecular profiles of the tumor and the host. The tumor is only half of the story. So the biology of both of those may be important when it comes to margins than just a few cells left at the margin. Certainly it looked that way from Mike Goldsmith Hume study with mast cell tumors that said low-grade tumors, even with tumor cells left at the margin, didn't recur, and a histological safe margin distance couldn't be predicted for high-grade tumors. So how that tumor's molecular profile, what host genes are present that can fight that tumor or not, may be very important things in the future. But I do want to leave you with, I love H&E, I love cytology. We just need to do those assessments in a standardized manner. So I've got no audience to look at. Poppy, Ratter, horses are part of JPC. Bruce, there they are. Horses have always been a big part of my life. I heard some of the activities from Pompey and others. So Jay, who's ever awake, Pompey, Juan, I'm done.
Thank you very much, Dr. Milton. It was a great lecture and such a very important topic. So thank you.
You're very welcome. I really do hope we get some feedback from other individuals, Juan. And I think this is where you move on to next.